final talk of this session will be given by Dr. Jennifer Ligibel from Dana-Farber Cancer Institute. Jennifer's talk is entitled Evidence Gaps That Current Trials Will Address, Gaps That Remain, and How These Gaps Can Be Filled. Jennifer.
Thank you very much, Andy. I will say that I hesitate slightly to launch into a talk after Robert's comments this morning that uses the word gaps 3 times in the title. But all kidding aside, as a medical oncologist, I talk to my patients all the time about how important exercise and nutrition and weight management is. And the reality is that for many patients, with the current resources that we have available, they just aren't able to make these changes. And so we really do need more evidence so that we can build the infrastructure for these programs and get them paid for so that our patients are able to access these things. So we're going to talk about the gaps in hopes that we can fill them and make these things more available. I want to start with a brief recap about what we know about weight, physical activity, and outcomes for cancer survivors. And I think we've heard a lot of data this morning that talks about the connections and the research that's already been done. Both Doctors Goodwin and Cornea presented a lot of observational evidence that shows that individuals who are obese, individuals who are inactive after cancer diagnosis have an increased risk of cancer recurrence and an increased risk of cancer-related mortality compared to people without those behaviors. And you can see here, this was a graph that Pam Goodwin showed looking at the relationship between body mass index and cancer-related mortality in women with early-stage breast cancer. So now more than 100 trials have evaluated this relationship and consistently show that heavier women seem to have a higher risk of recurrence and related mortality. Similarly, Dr. Cornea presented a number of studies showing the relationship between physical activity patterns after cancer diagnosis in the risk of cancer-related mortality. And we've seen that in breast cancer, colon cancer, prostate cancer, individuals who are more physically active seem to do better than individuals who aren't. We also learned a bit about the biology that could underlie these relationships. And although we don't know definitively whether metabolism or inflammation or differences in immunity are responsible for these observational connections, we can see that there are biologically plausible mechanisms that could directly affect cancer outcomes in patients who are overweight, obese, and inactive. And finally, from Dr. Irwin's talk, we learned about the many known benefits of exercise and weight management interventions in cancer survivors. And this really, as we saw, spanned an entire gamut from quality of life and fitness outcomes to many of the improvements in some of the common cancer-related symptoms and treatment-related symptoms that our patients experience. The other thing that we do know is that obesity and inactivity are very common in cancer survivors. On this graph, you see the proportion of women with newly diagnosed breast cancer who are obese and participating in a number of different adjuvant chemotherapy trials. And what you can see is that even though these studies largely enrolled patients 15 to 20 years ago, even at that time, about 30 to 40% of these women were obese. Similarly, studies have looked at the proportion of individuals after a cancer diagnosis who engage in regular physical activity. This was a survey that was done by the American Cancer Society about 10 years ago, and it showed that only about 1/3 of cancer survivors were engaging in recommended levels of physical activity, which was about 150 minutes of aerobic activity weekly. Many of these studies have also demonstrated that up to 1/3 of cancer survivors are doing absolutely no physical activity at all after diagnosis. So there are many unanswered questions, and I think the first and the most important, and we've talked about this a little bit already, is we know that there are these links between inactivity and obesity and poor outcomes. But what we don't know is if you take a patient who's diagnosed with cancer and is obese or is not exercising regularly and you change that, will that actually lower their risk of recurrence and help them to live longer? If so, what dose of intervention is needed and how long do people need to do it for? Is this something like chemotherapy where people need to do this for a number of months after their diagnosis? Or is this something that people need to do for years? We really don't have an answer to that question from the data that we have available. We also don't know what's most important. Is it weight? Is it exercise? Is it diet? And is that the same for all people, or does it vary by disease or by other characteristics of the patient? And finally, if we show these things are important, how do we actually get patients to do them? So I'm going to start by talking about a number of ongoing trials and see how these trials can answer the gaps that we have in the evidence. So Carrie talked about the first of these trials. This is the challenge trial, which is a randomized study that will look at the impact of a supervised exercise intervention on disease outcomes in individuals with early stage colon cancer. This is a large trial enrolling almost 1,000 patients, and it will look at whether patients who engage in this intervention have a lower risk of cancer recurrence, as we heard from Carrie. The other study that Carrie mentioned was the GAP4 trial in metastatic prostate cancer. Now, this is a very different study, and it's the only one of the trials that we'll talk about today that focuses on individuals with advanced disease, not looking at whether the intervention will reduce the risk of cancer recurring, but looking at whether in individuals with advanced prostate cancer no longer sensitive to hormonal manipulation, if exercise will actually help them live longer. As Carrie said, this is a 2-year randomized trial of a fairly intensive exercise intervention in these men, and it will enroll patients in 8 different countries across the world. There are a few other ongoing large-scale studies which will look at the impact of lifestyle interventions on disease endpoints in a number of other cancers. The first of these that I wanted to discuss is the LIVES trial that is led by Cindy Thompson and Dave Alperts. This trial, the Lifestyle Intervention for Ovarian Cancer Enhanced Survival trial, will enroll women with stage 2 to 4 ovarian cancer who undergo initial surgery and chemotherapy and have no evidence of residual disease after these standard treatments are completed. Women will be randomized to a 2-year telephone-based program that is structured to improve diet and activity, or to a contact time health education control group. The primary outcome of this trial is to look at the impact of this intervention on progression-free survival in these women. The intervention is a centralized telephone-based program that is offered in both English and Spanish. It's a multimodal intervention that involves telephone calls, print materials, text messages, emails, and a blog. It's grounded in social cognitive theory using motivational interviewing. And the primary goals of this intervention are to help patients consume more fruits, vegetables, and fiber, reduce fat, and increase daily steps. The control group receives an attention contact health education intervention that is also delivered via telephone. You can see here that this study has been accruing patients for about 5 years at this point through the NRG Cooperative Group and has enrolled 962 of its planned 1,070 patients. Looking at the first 529 patients enrolled, you see that the majority of patients who've enrolled in this study are non-Hispanic white, which reflects the demographics of ovarian cancer. You can also see that slightly more than 1/3 of the patients had a normal body mass index, and slightly fewer than 30% were obese. The majority of these patients who were enrolled had stage 3 disease, and given the fact that this is a population, unfortunately, with a very high risk of cancer recurrence, we will likely see results from this trial within the next few years. I also want to talk about a recently approved study that has started enrolling breast cancer patients, the Breast Cancer Weight Loss Trial, or BWEL study. This is a randomized trial that will enroll 3,136 women with stage 2 and 3 breast cancer who have a BMI of at least 27 kilograms per meter squared. They're randomized to a 2-year telephone-based weight loss intervention program or health education materials alone. The primary endpoint of the study is to look at the impact of this intervention on disease recurrence. We're using an endpoint that is commonly used in breast cancer chemotherapy trials called invasive disease-free recurrence of survival, which includes both distant and local breast cancer, contralateral breast cancer, second breast cancers or other cancers, and death from any cause. We're also interested in looking at the impact of this intervention on overall survival, distant disease-free survival, comorbidities, and health behaviors. Our weight loss intervention is a 2-year telephone-based program that's based on the diabetes prevention program, the Look Ahead study, and Pam Goodwin's LISA trial. Each of our patients is paired with a weight loss coach based at a call center at the Dana-Farber Cancer Institute, and they receive 42 phone calls over 2 years. The intervention is also accompanied by a number of materials like a workbook, a wireless scale, an activity monitor to help patients make their behavior changes. Our intervention goal is to help patients lose 10% of body weight through a 500 to 1,000 kilocalorie a day deficit and increased physical activity. Our study was activated at the end of August. It is currently open in almost 900 sites across the United States. For the initial 514 patients in our trial, we have a two-step process where they are initially registered and then we collect diet and physical activity over the course of 2 to 3 weeks. We have registered 292 patients in the first 5 months of study activation, and 234 of these patients have passed on to the randomization stage. The next steps of this trial will be activation in Canadian centers over the coming months. And we also plan on adding a Spanish version of our intervention this summer. There are also 2 other large-scale trials that are currently ongoing that will look at the impact of a lifestyle intervention on breast cancer outcomes. Both of these trials are being conducted in Europe. The first of these is the Dana-5 trial, which enrolled about 1,200 women with early-stage breast cancer in Italy, now about 8 years ago. These women were randomized to a usual care control group or to an intervention that included both dietary and physical activity changes. The diet in this study was a Mediterranean macrobiotic diet, and the patients are currently being followed for disease outcomes. The other trial also conducted in Europe was called Success-C, and this trial has a very interesting design in that this was embedded within a chemotherapy clinical trial. So patients were enrolled in the parent study and randomized to one of 2 adjuvant chemotherapy arms. Patients who had a BMI of at least 24 kilograms per meter squared were subsequently randomized to a telephone-based weight loss intervention or to a usual care control group. And about 1,400 of the patients who took part in the primary trial met the BMI criteria and have been included in the weight loss trial. The primary outcome from the chemotherapy randomization was reported a few years ago, and women are still being followed to look at the impact of the lifestyle intervention. So this is 6 large-scale trials that are currently being conducted looking at the impact of a lifestyle intervention on a disease outcome, recurrence or mortality in individuals with cancer. 3 of these trials focus on breast cancer, and all of these studies employ interventions that involve both dietary change and increased physical activity. They all enroll patients with early-stage disease and have outcomes looking at disease recurrence. The other 3 trials enroll different patient populations: Challenge, colon, GAP4 prostate cancer, and the LIVES trial looks at ovarian cancer patients. I think one of the other important things to note, as we said before, other than the GAP4 study, all of these trials look at the impact of a lifestyle intervention on disease recurrence. The prostate cancer trial is quite different, and I think will be very interesting given that there, at this point, isn't as much observational data linking physical activity and weight status to outcomes in the setting of advanced disease. So it'll be very important to know whether these findings also apply to patients who are living with advanced cancers. The other thing that's very important is that all of these studies are also collecting serial blood to be able to do biomarker and other correlative science analyses. So will these trials fill the evidence gaps? I think that these trials will clearly provide definitive evidence regarding the impact of increased physical activity and weight loss in specific populations. And these include common malignancies. Breast cancer is certainly where the bulk of the evidence has risen linking lifestyle to cancer outcomes. However, we have to recognize that each of these trials really looks at these specific populations in a signal malignancy. Some of the trials will be large enough to look at subsets. The BWEL trial is powered to look at the impact of the intervention in pre- and postmenopausal women and in women with hormone receptor positive and hormone receptor negative breast cancers. But I think we recognize, after hearing Pam and Carrie's talks, that there's a lot of observational evidence linking these factors to outcomes in a wide variety of malignancies. And one of the questions is, can you take the knowledge that we will gain from these studies and be able to apply it more broadly to cancer survivors? And I think one of the keys to this is the correlative science that's embedded in each of these large trials. All of the studies collect serial fasting blood from participants in both the intervention and control arms over time. Several of the trials also include baseline collection of tumor tissue and benign tissue, and many of them collect DNA either from blood or saliva. This is important, first, because it will help us to identify predictors of intervention benefit. We're able to do this using patient characteristics like age and BMI from the larger studies, but if we're able to look at things like baseline insulin levels, baseline levels of inflammatory markers, SNPs, we'll be able to predict which patients are likely to derive benefit from these interventions. Then in the clinical setting, we can apply these interventions to the people most likely to derive benefit, and we can keep looking for interventions that may be likely to help others that may be less likely to derive benefit from these programs. I think the other important piece of the correlative science opportunities is the development of intermediate biomarkers. In cardiovascular disease, when you're trying to look at the evaluation of a new agent to see if it will lower the risk of myocardial infarction, you can look at an intermediate biomarker like blood pressure or like cholesterol levels. We don't have these types of markers in cancer, and so in order to look at the impact of an intervention on outcomes, we need to do these large-scale trials. If we will able to demonstrate that the way in which a lifestyle intervention reduced the risk of cancer recurrence was by lowering estrogen or lowering insulin or having a favorable effect on inflammation, then we could do smaller trials that would look at the impact of these interventions on these intermediate markers, and we would be better able to compare different interventions. When we looked at all of the intervention studies that are going on, none of them compare diet to exercise to weight loss. For feasibility reasons, we were only able to select a specific intervention in a specific population, but if we were able to establish an intermediate marker, we could do trials that looked at a variety of different interventions and figure out which was most effective in lowering or affecting the biomarker of interest. And as an example of that, there are a number of trials that have been done in the past, which if we were able to establish these intermediate markers, would provide much greater insight into what led to cancer recurrence. So this is one example of this. This is the new trial. This was a trial that enrolled 439 sedentary, overweight, or obese postmenopausal women who are at risk of developing breast cancer and randomized them to an exercise intervention, a dietary caloric restriction intervention, or the combination. What the trial showed was that weight loss led to significant reductions in all of the biomarkers identified. In this trial, we were able to say that these interventions had an impact on these biomarkers, but if we knew that by lowering insulin levels you could improve prognosis, then this study would provide insight into what types of interventions would be most effective. Similarly, the CHOICE trial was another study that looked at different types of intervention and how they affected biomarkers that had been linked to cancer. This trial enrolled breast cancer survivors who had a BMI between 25 and 35 and allowed patients to choose a low-fat or a low-carbohydrate diet or a usual care control group. The study demonstrated that both weight loss groups lost about the same amount of weight, whether they chose the low-fat or the low-carbohydrate dietary pattern, and that reductions in fasting glucose were similar between the two groups. Even more importantly, when you looked across the two groups, the biggest driver of the decrease in fasting glucose was the amount of weight loss that was achieved. So we look at this study and we say, well, that's interesting that you can reduce glucose levels with these interventions, but if we are able to show that a reduction in glucose actually led to improvements in outcome, then this type of study would be something that would help us determine what types of interventions would be most promising to improve outcomes for our patients. One of the other unanswered questions that we have is, do these studies provide a path to show us how to help our patients become more active, how to help them lose weight? I think one of the important things, most of these trials have used the cooperative groups to enroll patients, and this means that there are a large number of centers which are enrolling patients. This can increase the diversity of the patients that are enrolled, and so this is something that I think helps us to feel confident that these studies can provide some real-world information about how these types of interventions can be employed in cancer survivors. Another important aspect is that many of these studies use a telephone-based approach. And as we're thinking about how do we connect with patients in rural areas and patients who live in underserved places, the telephone and other distance-based approaches are very appealing. But I think one of the things that's quite striking is that the two interventions that specifically focus on increasing exercise have a significant supervised component, and I think this is not by accident. Although there have been studies that show that you can increase physical activity through telephone counseling or other distance-based approaches, the reality is that most of these studies have led to a relatively modest increase in physical activity. And we also recognize that cancer survivors many times have a number of comorbidities and side effects from their therapy that can make it hard to implement a distance-based intensive activity program. So I think this is another one of the gaps that these studies may not address, is how do we really implement widespread physical activity programming in cancer survivors. Later on in this conference, we'll hear about some ideas for ways that that could be accomplished. One of them is by using community-based programs like the Live Strong at the YMCA program. This is now available in more than 500 YMCAs across the country. And although it's a relatively short 3-month program, this could be something that would help people become active. And then, as Carrie's study has looked at, using maintenance with more distance-based approaches for people who've already started an exercise program. Katie Schmitz will also talk about her Strength After Breast Cancer program, which uses a similar structure of an initial in-person intervention that then transitions to a home-based exercise program. And I think the other piece that we heard about a little bit earlier from Robert, as well as from Karen, is the use of technology. And I think this is something that is rapidly emerging and may help us as we're trying to implement distance-based exercise interventions over the years to come. Fitbits and other types of wearable activity sensors are pretty ubiquitous. They can connect health coaches with patients in ways that was never possible before. Coaches can see what patients are doing and increasingly can look at biometric data, things like heart rate and blood pressure. Mobile platforms like Skype allow a trainer to really work with the patient and look at their form and make sure that they're not doing something that might be dangerous. But I think we also have to recognize the limitations of this technology and not think that technology can take the place of the types of interventions that have been developed over the last many years that have shown successful ways of helping people incorporate behavior change over time. So I just wanted to finish with thinking about, we have all this information that's coming from these trials. What steps could we take to make this more generalizable? I think that there are clearly paths through correlative science to help us understand within a disease how these findings can help us figure out which patients, which interventions, what's beneficial and what's not. But I think one of the struggles that as an oncologist I see is how can we apply this across multiple malignancies? The paradigm for treating cancer patients has become so much more complex in the last 5 to 10 years. And as an oncologist, I focus much more now on an individual patient and subtypes of diseases. So I think one of our biggest challenges will be thinking about how we can take the information we gain from these trials and try to generalize it to other malignancies, because unfortunately, it's just not realistic that we're going to have the ability to conduct randomized trials in every cancer with all of these different interventions over time. So to finish, I do think that the ongoing trials will address a number of the gaps in our knowledge. I think we'll have really definitive evidence for the first time regarding the impact of increasing activity and losing weight on cancer outcomes in some of the most common malignancies that we see. I do think that correlative work also provides the key to extend our findings beyond the specific populations and the specific interventions that we're evaluating. But I think that there's a lot that we're going to need to still learn about dissemination, both within different groups of people and how we take this knowledge and apply it to cancer more broadly. Thank you.